Hi there, this is Trip Buckley. Thank you for joining us for this Endoscopy Now live webinar. We appreciate you joining, and we'll be starting here, well, right now. So hopefully we're going to have a great talk and great discussion afterwards. So let me introduce Vani Konda to begin with. She is an associate professor at Texas A&M College of Medicine. She's at the Baylor Scott and White Clinic in Dallas and directs the Center for Esophageal Diseases. And we're also joined by Dr. Elisa Ferre, who is also my partner at the University of Texas Austin Dell Medical School. And she's an assistant professor of surgery, and she heads our heartburn and esophageal disorders clinic. So thanks to our sponsors. We couldn't do this certainly without you. That's Castle Biosciences and Medtronic. So thank you to them. And without further ado, go ahead, Vani, take us away.
Thank you, Trip. It is such a pleasure to be here with you and Elisa tonight to talk about my favorite topic, novel innovations in Barrett's esophagus and early esophageal cancer. Here are my relevant disclosures. As we are aware, esophageal adenocarcinoma, the predominant form of esophageal cancer in the West, has an incidence, as shown here in the blue curve, and a mortality, as shown here in the red curve, that have been steadily rising over the past several decades. Fortunately, we have a precursor lesion, which is Barrett's esophagus. It is a known risk factor for esophageal adenocarcinoma, and it is the replacement of esophageal squamous lining with specialized intestinal metaplasia, and it is a complication of chronic reflux. The diagnosis of Barrett's esophagus requires both the endoscopic appearance of salmon-colored mucosa in the tubular esophagus, as well as the histologic component, which is columnar-lined epithelium with the presence of goblet cells or specialized intestinal metaplasia. There is high interobserver variability among pathologists to diagnose dysplasia, and it is difficult to distinguish dysplasia from inflammation, which is often present in this reflux-rich environment. Expert GI pathologists have less variability, and therefore it is important to confirm dysplasia with an expert GI pathologist. Now, we do not recommend a screening endoscopy for everyone because it is not cost-effective and it likely doesn't benefit everyone in the general population. We do recommend endoscopic screening for those patients with multiple risk factors, and we focus on chronic reflux. We also have a lower threshold for those patients who are men compared to women, and we look at the other multiple risk factors such as age, race, hiatal hernia, family history, central obesity, and smoking. And non-endoscopic screening is now an option and is likely to be a game changer for screening. And this is important because we have to acknowledge that our screening paradigm is imperfect. Studies suggest that at least 40% of those patients who with esophageal cancer did not complain of heartburn and regurgitation, and that somewhere around 95% of patients with esophageal cancer that underwent surgery did not carry a previous diagnosis of Barrett's esophagus, suggesting that our screening criteria, which are heavily focused on reflux and require endoscopy, are not capturing many patients who end up getting esophageal cancer. New cell collection devices provide a way of gathering cells in the esophagus without a sedated endoscopy, which can carry cost, risk, and inconvenience. Cytosponge, for example, has been developed by Rebecca Fitzgerald in England and allows a tethered encapsulated sponge to be swallowed, and then the capsule is dissolves in the stomach, and the sponge is withdrawn back through the esophagus, collecting cells, which can then undergo immunocytochemistry staining, and that assay, specifically Trefoil factor 3, can denote the presence of specialized intestinal metaplasia. And the recent BEST-3 trial, which was a randomized controlled trial, showed a 10-fold increase in the detection of Barrett's among those patients who are offered cytosponge compared to the usual care group. A variety of these non-endoscopic cell collection devices have also been coupled with DNA methylation markers and are demonstrating promising results and with ongoing studies for validation. Patients diagnosed with Barrett's esophagus without dysplasia are recommended to have surveillance endoscopy with a biopsy protocol with intervals of every 3 to 5 years. But it's important to recognize the Seattle protocol is a standard protocol to assess for occult neoplasia and requires the biopsy of visible lesions, followed by random 4-quadrant biopsies every 1 to 2 centimeters, specifically 1 centimeter in the history of dysplasia, throughout the segment looking for occult neoplasia. Limitations to this protocol, however, include poor adherence, sampling error, and poor adherence is associated with missed neoplasia, which is unfortunately even worse in longer segments. Detection of visible lesions can be subtle and challenging, and unfortunately lead to missed cancers in endoscopy, with one meta-analysis showing a quarter of patients who were diagnosed with an esophageal cancer who had a previous endoscopy had that endoscopy within 1 year of diagnosis. The critical piece of surveillance is a high-quality endoscopic examination. There have been numerous guidelines, recommendations, best practices, and reviews that list out what we should be doing during a high-quality endoscopic examination. To make it easy, I call these the 5 L's. Essentially, endoscopists should identify esophageal landmarks, measure the length of the Barrett segment, take time to look for subtle lesions, and then identify and target those visible lesions. And then the rest of the segment should be assessed with multiple levels to assess for occult dysplasia. The most investigated and widely used enhanced imaging technique is virtual chromoendoscopy, specifically narrowband imaging, which is a filtered blue light. This can enhance mucosal patterns and vascular patterns. And a simple classification system can denote these patterns as either regular or irregular, with irregular patterns being concerning for neoplasia. Here is an example of a short segment of Barrett's esophagus as seen by white light endoscopy with high resolution endoscope and a soft distal attachment cap fitted to the tip of the endoscope. We can see here that this patient has a neoplastic lesion. They're harboring that lesion if we look at the clock face from 12 o'clock to 4 o'clock. And sometimes these lesions are subtle, and insufflation and deflation can make it easier to appreciate the lesion. Narrowband imaging can also be used to look at the mucosal pattern of this lesion, looking specifically at the distorted pit pattern, as well as the irregular vasculature, making it concerning for neoplasia. And looking under narrowband imaging, we can also start to suspect that there's subsquamous extension of this lesion. And again, you can see this area from 12 to 4. I also used confocal laser under microscopy to help delineate this lesion in preparation for endoscopic resection. It's important to understand when we see these lesions what we're dealing with, and really we have to understand the risk of lymph node metastasis. It helps clarify who needs surgery and who can be treated endoscopically. Intramucosal carcinoma, or T1A, carries a minimal risk of lymph node metastasis, making it amenable for endoscopic resection, whereas T1B lesions, or submucosal cancer, carry a much higher risk of submucosal invasive disease and of lymph node metastasis, and therefore may require surgery and or systemic therapy. High grade by biopsy alone can be associated with a 40% risk of prevalent cancer. However, most of these lesions are intramucosal, and there's a shared management approach among patients with high-grade dysplasia and intramucosal carcinoma. The risk for submucosal cancer is in the minority of these cases with high-grade dysplasia, but it is higher in visible lesions, particularly those that are protruding or depressed. And it is important to characterize and document the visible lesions with the Paris classification, which can also help us identify that risk. And it is also the reason why all visible lesions should be resected with endoscopic resection for a definitive diagnosis. And it's because EMR can change the diagnosis up to half the time. While EUS is appropriate for nodal staging, it's inadequate for early T staging. There's also less interobserver variability among pathologists with EMR. Now, in that case that I showed before, we can see a widely available technique of endoscopic resection, which is the band-assisted endoscopic mucosal resection technique. This lesion was marked, and then it is used to, the suction is used to draw up the lesion, and then a band is deployed, and a snare cautery is used to then resect the lesion. This can actually be repeated multiple times to perform wide field EMR, as in this case. And then we get an accurate histology. And in this case, this was a T1A lesion with muscularis mucosa invasion. Additional ways we can detect or improve detection for these important visible lesions include artificial intelligence. A few computer-aided detection systems have been developed. For example, the Argos project yielded this computer-aided detection system, which has recently published one of its benchmarking studies. We can see here that in blue dots, we see the performance of 52 general endoscopists in the detection of a test set with specifically subtle lesions. The computer, as shown in the red dot, demonstrates a sensitivity of 84% compared to the overall sensitivity of the general endoscopist, which was 63%. These computer-aided detection modalities can identify and help target the endoscopist's eye to better target biopsies and resections. Another technique that we can use to improve our detection is Watts 3D, or wide area transepithelial sampling. This is where we take an abrasive brush and brush the lining of the esophageal mucosa, and we're able to collect cells. These are then fixed, and a computer generates a 3D image construct, and then a neural network identifies concerning areas, which then are confirmed by a pathologist. A recently published meta-analysis demonstrates that 15% of cases were diagnosed with forceps biopsies for dysplasia, with an additional yield of detection of dysplasia of 7.2% by Watts. These cases with discrepancy are also interesting to understand, because in those cases where forceps can diagnose dysplasia in 232 cases, Watts was negative in almost 2/3 of those cases, suggesting that these modalities best complement each other, and Watts does not necessarily replace forceps biopsies. We also are informed by risk of progression to cancer. The annual cancer incidence among patients with high-grade dysplasia is 6 to 12%. The overall rate of low-grade dysplasia is quoted to be 0.5 to 0.6% per person per year. And patients without dysplasia have a risk of 0.3% or less per person per year. High-grade dysplasia is the best marker that we have to identify who goes on to develop esophageal cancer and who best benefits from endoscopic therapy. Another marker for progression is P53. Absent or aberrant expression with P53 can show who might be at increased risk for progression to high-grade dysplasia or esophageal adenocarcinoma. A meta-analysis that we performed showed an odds ratio of 3.4 among case control studies and a relative risk of 17 among 7 cohort studies. It may be that a panel of biomarkers may provide more information and better risk stratification. A commercially available test called TissueCypher includes P53 and the following biomarkers as shown here, with a total of 16 features that also includes morphologic assessment. This assay can be used on archival specimens, and a software provides a risk score of 0 to 10, which can then be grouped in a risk class of low, intermediate, or high. In a pooled meta-analysis from the Mayo Clinic, a high-risk class by TissueCypher was able to significantly demonstrate prediction of progression compared to clinical variables alone, twice that to what's delivered by expert GI pathology review assessment of low-grade dysplasia. And this is both when compared directly as well as in logistic regression models. So sometimes it's tricky to explain all of that to patients. So this is how I explain it to patients.
Imagine you are in a train station with multiple trains going to multiple destinations, and one of those destinations is esophageal cancer. Patients who have high-grade dysplasia are on that train going to esophageal cancer. We can't know if the cancer is the next stop or if it is 5 stops from now, but you're heading in that direction. And we're going to do whatever it takes to get you off that train to keep you from getting esophageal cancer. We are going to cut it, burn it, or freeze it, and accept that there may be some risk associated with these procedures in order to get you off that train. For those patients who have low-grade dysplasia, we need more information to determine if you're high or low risk to go on to develop cancer. It is like you're in a ticket line. You may be getting on that train, and it is the right time, but we don't know that you'll actually get on that train. We might need more information by looking at your ticket, by doing another endoscopy, a TissueCypher test, or doing an endoscopic mucosal resection of a lesion before deciding about therapy. If you have no dysplasia, consider that just being present in the train station, but not likely getting on that specific train. We consider your risk of developing cancer as very low, although we may perform an endoscopy with more rigorous evaluation or an additional test like TissueCypher to be sure you are not getting on that train later.
So when we look at these modalities for treatment, we can broadly divide them into tissue acquiring and non-tissue acquiring. And it's important to remember that tissue acquiring allows us not only to remove the lesion, but allows us an accurate histopathologic specimen for diagnosis. And these management strategies are informed by risk. The low risk of progression allows us to survey those with non-dysplastic Barrett's. The high risk of progression or prevalent cancer endorses a treatment strategy for those patients with high-grade dysplasia. And low-grade dysplasia allows for endoscopic eradication therapy, but surveillance is also an option. As mentioned, we can further risk stratify these patients, and individual decision-making is important. This is the crux of some of the Barrett's treatment questions, and currently a randomized controlled trial looking at treatment versus surveillance in these low-grade dysplasia patients is currently underway in the United States. And the risk of lymph node metastasis in patients with submucosal carcinoma does support surgery and or systemic therapy. But I will say specifically, there is a subset of patients of low-risk submucosal disease that's superficial that may benefit from endoscopic therapy, and this is well characterized by the German experience. Endoscopic eradication therapy is based on the concept of total Barrett's eradication, which not only resects the known neoplasia, but also treats the rest of the at-risk epithelium to treat any metachronous or synchronous lesions. This can be done by complete endoscopic mucosal resection in a piecemeal approach with 96% rate of complete eradication. However, the complications include a 2% perforation rate, as well as a third of patients develop strictures. Radiofrequency ablation allows delivering thermal energy to the esophagus with a variety of different footprints, including a circumferential balloon or focal devices that can be over the scope or through the working channel. And this has excellent eradication on the order of 95%. It's important to appreciate the long-term studies that have come out of this experience, which also suggest that recurrence can occur of intestinal metaplasia in a third of patients, as well as 17% specifically for dysplasia, endorsing surveillance after endoscopic therapy, even after eradication of disease. Ultimately, a hybrid approach has become the standard approach to take advantage of the benefits of each therapy, where visible lesions are removed, we get a diagnosis with the histology, we ablate the rest of the lining, and then ultimately we want to replace the whole lining with neosquamous epithelium. This hybrid approach has excellent success of 93% and a more favorable complication profile compared to complete EMR. We also have some additional ablative strategies, including cryotherapy. And here we can see the cryospray, which utilizes liquid nitrogen, which freezes the mucosa on contact, and the cells actually die during the thawing process. A meta-analysis of both naive and failed RFA cases demonstrate an eradication of 84% with this technology. We also have a cryoballoon technology, which allows us to deliver the agent, which is nitrous oxide in this case, through a balloon catheter. And we can deliver a freezing therapy, which creates an ice patch. And this can actually be controlled both along the axis of the balloon as well as rotationally around the axis of the balloon. And multiple studies show this to be as efficacious as RFA. Hybrid APC is another technique that allows the combination of lifting the mucosa off the muscle layer with an agent like methylene blue using a high pressure water jet, and then using APC to ablate the mucosa while protecting the muscle with a submucosal cushion. A European trial demonstrates complete eradication of intestinal metaplasia on the order of 88%. And finally, I just want to mention ESD, which provides an en bloc specimen. It's indicated in most cases with squamous cell neoplasia, and it is shown that EMR piecemeal is non-inferior to ESD with most cases of Barrett's esophagus with high-grade dysplasia or intramucosal carcinoma, but ESD can be beneficial in those cases where you have a concern for submucosal carcinoma, a large or bulky lesion, or a non-lifting lesion. In conclusion, non-endoscopic screening devices may be coupled with biomarkers to capture a broader population to better identify who is at risk for esophageal cancer. Detection and resection of visible lesions is critical to diagnose and treat disease. Risk stratification is helpful to decide who may best benefit from escalation of care, and endoscopic eradication therapy is a standard treatment for Barrett's associated neoplasia. Thank you.
Wow, thank you, Vanny. That was a lot of ground to cover, and I've got lots of questions. And just to tee up some, it's going to be around, looking at the ACG guidelines and how you're actually practicing. So a lot of good material there. I think we're going to have a lot of good questions at the end. Speaking of which, if you have a question, please put it in the Q&A, and I will ask that question to our panel. As Elisa is spooling things up, a couple of other just brief housekeeping events. There is going to be a survey at the end of this. We would really appreciate your feedback on the content and discussion, so please stick around for that. Also, if you're viewing this on a mobile device, please, and you lose your connection, just please reopen the app and go to virtual ed, and we'll get you back in. So once again, and thanks to our sponsors, Castle, as well as Medtronic. And without further ado, my partner, Dr. Elisa Ferre.
All right. Thank you so much, Trip. Can you guys hear me okay? My headphones messed up and now I'm concerned about my audio.
Can hear you.
Okay. All right. Well, I am excited. Thank you, Dr. Konda. That was great kind of overview of the latest and greatest that is going on with Barrett's and endoscopic treatments for that. And I have the pleasure of talking to you guys about kind of surgery and its impact on a Barrett's esophagus, as well as Barrett's esophagus associated neoplasia. So I kind of have my own objectives that I want to get across to you guys. One of them is understanding when anti-reflux surgery is indicated for Barrett's esophagus. I also want to harp on understanding the impact anti-reflux surgery has on the progression and outcomes of Barrett's esophagus. And then when esophagectomy is needed in patients with early Barrett's esophageal neoplasms. Give me 1 second. I need to get my face out of there. Okay. So when to consider anti-reflux surgery in Barrett's esophagus. So when I think about patients with Barrett's esophagus, I think that, okay, these patients, Barrett's esophagus is an objective evidence of chronic reflux, as Dr. Kanda kind of mentioned. So the first time, or when I consider patients for anti-reflux surgery, is when it's kind of the same indications that I have for patients normally for anti-reflux surgery. So these are going to be patients with persistent troublesome reflux symptoms with objective evidence of GERD despite optimized PPI therapy. And, patients with Barrett's esophagus already have objective evidence of GERD. So these are going to be patients that are medically refractory. And so kind of going back one step further is what causes GERD. So when we talk about reflux, we talk about dysfunction of the reflux barrier. And this is a picture that was released by AFS, just describing kind of this anti-reflux barrier. It's composed of 3 things. One of them is the crural diaphragm, which is both a physiologic and a mechanical barrier. The other is a gastroesophageal flap valve, which is really created by that angle of His that you can see here in that middle picture. And then the last is the lower esophageal sphincter, which is largely a physiologic or functional barrier. So how does anti-reflux surgery work? So I like to think of it as we're fixing the barriers. So usually we're fixing 2 of these things. So usually the crural diaphragm. So what we're doing is we're combining a hiatal hernia repair cruroplasty, where we're actually, fixing hiatal hernia or tightening that crus around the esophagus. And then combining it with either reformation of this gastroesophageal flap valve by recreating this angle of His, and we can do that with different types of named fundoplications that you see here, with the ultimate goal of recreating this valve that you can see on this right picture of that we take intra-op endoscopy. And then also you can use endoscopic modalities to recreate the valve, such as transoral incisionless fundoplication, or TIF, which is seen here. Again, the whole goal of the fundoplication is to recreate that flap valve. Or we can combine the cruroplasty with the lower esophageal sphincter augmentation, or LINX, which you can see here, which really augments that lower esophageal sphincter. And so the reason I bring up reflux in general is that that's kind of the first indication where I think surgery is indicated for patients with Barrett's esophagus. It's going to be, I think of surgery similar to as we use PPIs for symptoms. So patients that have Barrett's esophagus that are symptomatic despite maximum or optimized medical therapy, those are the patients that I'm going to consider initially for anti-reflux surgery. This was a study that kind of looked at quality of life assessment before and after surgery in GERD patients with and without Barrett's esophagus. This specific table is just looking at patients with Barrett's esophagus. So this is quality of life scores before their anti-reflux surgery and then after. Just to note, the higher scores reflect a better quality of life. So even after 3 years after laparoscopic anti-reflux surgery in patients with Barrett's, there's maintained improvement in their quality of life. So that's first and foremost, just to get that out of the way. And then let's look at the anti-reflux surgery impact on Barrett's esophagus. So there's a lot of talk. I know when I first started learning about Barrett's as a resident, and then learning about kind of anti-reflux surgery as a resident, in my mind, it was, okay, do surgery and the risk of cancer should go away. And it's not entirely the case. So I'm going to show you a couple studies kind of looking at long-term outcomes of anti-reflux surgery in patients with Barrett's esophagus, especially looking at what happens to their Barrett's esophagus. So this was a retrospective review looking at patients with Barrett's who underwent anti-reflux surgery, and they had a 5-year follow-up. So the majority of these patients actually had long segment Barrett's. It was 85 patients, and they looked at pre and post-op quality of life scoring, pre and post-op pH testing, as well as pre and post-op EGD and histology. And what they found was that 90 or 79% of patients had resolution of reflux symptoms. They had normalization of their pH in 81%. And then more importantly, though, is looking at their Barrett. So low-grade dysplasia patients ended up becoming complete resolution of their dysplasia in 44% of patients, and then they had complete resolution of intestinal metaplasia or CRIM in 14% of patients. So a significant amount of patients regressed, but there was patients that did progress to low-grade dysplasia in 6% of patients. Looking at this, another retrospective review, again with 5-year follow-up or greater, they were able to show that after anti-reflux surgery, patients with Barrett's esophagus, regression was seen in 31% of patients, but progression, again, occurred in about 8%. So the last study I showed was 6%, now we're at 8%, and they were able to show that that patients were 7 times more likely to have a failed fundoplication or have a risk of progression with a failed fundoplication. They also demonstrated that the rate of progression was of non-dysplastic Barrett's esophagus was almost 1% per patient year. And then this is actually a head of print that I found, and it was accepted just last month. And I thought this was, I mean, the numbers are massive. But this is looking not at progression of Barrett's to dysplasia, but looking at overall esophageal adenocarcinoma progression. And so this was a retrospective review in the Netherlands using national registries. They were able to identify patients with Barrett's, and then they were able to compare those to national cancer registries. And they divided 3,000, almost 34,000 patients into anti-reflux surgery arm and anti-reflux medication arm, with a pretty significant follow-up up to 32 years, but average was 5 years for anti-reflux surgery and 11 and a half years for medication. So what they found was that 14 or 2.5% of patients in the anti-reflux surgery arm progressed to cancer, and 1.3% in the medication arm. They calculated the hazard ratio as 2.2, and this is when they controlled for actually endoscopic therapy in patients in the medication arm. And this was actually increased. So the hazard ratio was increased in the anti-reflux surgery group compared to the anti-reflux medication group. I don't think that this means, and they even comment in the paper, that it doesn't mean that, you know, the anti-reflux surgery is causing patients to be at higher risk for cancer progression. But it does speak to that the diseases that kind of lend themselves to ending up in a surgeon's office and getting surgery are more severe than maybe those that are content on their medications. And that was kind of why they thought that maybe there was an increased risk in that population. But what I want to kind of bestow on you guys is that overall, there's a bunch of studies, those are just kind of a couple, but anti-reflux surgery it has been shown to result in regression after long-term follow-up of Barrett's esophagus, but it does not ultimately impact their overall progression to dysplasia or esophageal adenocarcinoma. I like to tell patients when I'm operating on them that this is an anti-reflux surgery. It is not an anti-cancer operation. You must continue surveillance in these patients, especially given that up to 5 to 10% of patients will progress despite having control of their having good acid control. So another reason to consider anti-reflux surgery in Barrett's esophagus is to achieve complete resolution of intestinal metaplasia after endoscopic eradication therapy. So a couple studies. One, this is it was a retrospective review who evaluated patients who achieved CRIM after RFA. So these are patients that had a good response to endoscopic eradication therapy. And then they were divided into patients that underwent PPIs alone afterwards, or patients that went on to get a laparoscopic Nissen fundoplication. There was a 2-year follow-up. And the results were that 20% of the patients in the PPI group had a recurrence of their Barrett's esophagus versus 9.1% in the laparoscopic Nissen fundoplication group. Overall, when looking at those two groups, that was not significant difference in recurrence, but when they broke down into the type of Barrett's, so they looked at patients which they considered long segment Barrett's, which was greater than 4 centimeters circumferential length, that those patients actually did show a significant improvement after laparoscopic Nissen fundoplication in decreasing rates of recurrence after of their Barrett's esophagus after endoscopic eradication therapy. So just a kind of a subpopulation that may benefit. And then this was a multi-institutional retrospective review after, again, eradication therapy with laparoscopic Nissen fundoplication. So 49 patients underwent endoscopic eradication therapy and then a Nissen fundoplication. What they saw was that in 53% of patients that achieved CRIM, that they maintained CRIM in 70% of those patients after laparoscopic Nissen fundoplication. There was 30% recurrence rate of non-dysplastic Barrett's after 2 years. And then in the other population, which they looked at, was this complete resolution of dysplasia. So 16% of patients achieved the eradication of their dysplasia. And after laparoscopic Nissen fundoplication, they were actually able to achieve fully to CRIM in 62.5% of patients after 2 years. And one patient ended up progressing to low-grade dysplasia, but he initially had high-grade dysplasia. No patients developed high-grade dysplasia or cancer in this population. So what was shown after this is that, you know, although they did look at in patients that had achieved CRIM and underwent laparoscopic Nissen fundoplication compared to PPI, there was no difference in durability of the endoscopic therapy. But the special group that may benefit in laparoscopic Nissen or an anti-reflux surgery after endoscopic eradication therapy would be in patients that had failure to achieve CRIM after dysplasia was eradicated, or patients that had achieved and need to maintain CRIM. So overall, the durability in patients with endoscopic eradication therapy after anti-reflux surgery. So for all comers, there really was no change in recurrence rates of Barrett's with anti-reflux surgery versus PPIs after CRIM was achieved. There may be an increased durability of the endoscopic eradication therapy or CRIM in longer segment Barrett's, and it may also be used to achieve CRIM in patients that have already have only achieved resolution of their dysplasia. So those are kind of the two populations that you may want to consider it. So then it's when to consider esophagectomy for early Barrett's esophagus associated neoplasia. So as Vanny kind of mentioned, you know, early esophageal cancer is kind of considered these high-grade dysplasia. Early esophageal adenocarcinoma is the T1A lesions, which are going to be into the lamina propria or the muscularis mucosa, versus the T1B lesions that invade into the submucosal layer. And that's what I'm focusing the rest of this talk on. So what we know from historic data is that historically patients used to undergo esophagectomy for high-grade dysplasia. So using kind of those older cohorts, the prevalence of esophageal adenocarcinoma in all comers getting esophagectomy for high-grade dysplasia was almost 40%. I think that that's important that we know that it's 40%, but I don't think that I think that's an overestimation of who would benefit from esophagectomy. I don't think 40% of patients were missing because those are for all comers. Those are going to include your T1A lesions and your T1B lesions. So, or greater or worse, I guess. What they did also find was that about 13% were found to have submucosal esophageal adenocarcinoma. And as Dr. Konda explained, as these tumors progress into the submucosa, that risk of lymph node metastases is greater. And so those are the patients that we're trying to identify of who, you know, would benefit from these esophagectomies when the mortality of esophagectomy is greater or less than the risk of their lymph node metastases. Those patients would benefit. So this is a review of a national cancer database, and it's looking at all patients that had early esophageal adenocarcinoma, that had a primary esophagectomy and at least 15 lymph nodes harvested. And then they just looked back at those specimens and saw what were the independent predictors of lymph node metastases. So what they found was that submucosal invasion, as we've talked about why that's important for lymph node metastases, the lymphovascular invasion was associated with increased risk, decreased differentiation, so those patients with poor differentiated tumors, and then tumor size greater or equal to 2 centimeters. And so what they further went on to talk about was this T1A high-risk patient versus a T1B low-risk patient. So a T1A patient with poor differentiation actually had a lymph node metastasis rate in this study of 6.7%. So an overall 90-day mortality after esophagectomy in this group of patients was 3.1%. So if you look at that, their lymph node metastases rate was higher than their mortality rate. So in even a T1A patient with some of these risk factors, they may actually benefit from an esophagectomy, depending on a slew of factors. Similarly, a large T1A lesion greater than 2 centimeters had carried a lymph node metastases rate of about 10.2%. And then conversely, T1B lesions, which as Dr. Konda kind of had mentioned, there are a special subset that we may not need an esophagectomy in. This might be useful information to kind of help stratify that. But so a T1B lesion that's well differentiated and less than 2 centimeters, the lymph node metastases rate was 4.2%. The overall 90-day mortality was 6%. So that lymph node metastases rate was lower than the 90-day mortality rate. So potentially avoiding esophagectomy in that patient may be useful. And then this is speaking more to those superficial T1B lesions. So this was a review of 123 patients with either suspicious on EUS or definitive after endoscopic or surgical resection of the SM1 or those very superficial T1B esophageal adenocarcinomas. And what they did was they analyzed these patients separately for what they considered low-risk lesions, which were low-grade or, the well and poorly differentiated were low risk, no lymphovascular invasion and no vascular invasion. And then high-risk patients were characterized as poorly differentiated with lymphovascular invasion and vascular invasion. And then they divided the group into either low risk or high risk. And what they found was that low-risk patients had a 2% risk of lymph node metastases and 9% in the high-risk group. Mortality overall in esophagectomies in this group was 3%. And what they found was that lymph node metastases in T1B, superficial T1B lesions with a low-risk pattern was the lymph node metastasis rate was lower than the mortality rate. And in those patients, again, as I had kind of spoke to that last study, those patients could potentially avoid esophagectomy and just get endoscopic resection. And then sort of looking at the other side is what do you do not with a lesion that you know and you can kind of characterize is what do you do with these failed endoscopic eradication therapies? I know Dr. Konda mentioned the cryotherapy as an option, but this group reviewed all patients that underwent esophagectomy for failed endoscopic therapy in patients with high-grade dysplasia or intramucosal carcinoma. It was a small group, so only 15 patients. And prior to esophagectomy, they had about 4 sessions of endotherapy, and they were referred to esophagectomy for either progression of disease, failure to clear disease, or recurrent disease. And what was found is that about 20% of patients had T1B lesions, 7% had a T2 lesion, so these would be more aggressive cancers, and 20% had lymph node metastases. All of those were in patients with T1B or higher. Although none of this reached statistical significance, I think it's an important study to note because all the patients that ended up progressing did have a more advanced pathology on index endoscopy. So they had the intramucosal cancer, and they had more prior endoscopic eradication therapy sessions. So, which in the group that ended up having lymph node metastases had a median of 6.5 sessions versus 3. So there is a lot of talk that patients have had failed eradication of their dysplasia after 3 sessions should be potentially considered failure of therapy and sent to a surgeon for a possible esophagectomy. And so this is actually a review article by Dr. Konda. She's one of the authors on it. But there was a nice table in here. I didn't include every single thing from that, but basically characteristics of high-grade dysplasia lesions that are associated with esophageal adenocarcinoma, submucosal invasion, and lymph node metastases, because that's ultimately, I think, what we're trying to capture is those patients that have the potential and have metastasized to the lymph nodes. And so some of those risk factors are long segment, multifocal dysplastic Barrett's. So in a long segment of Barrett's, you have many areas that show dysplasia, that there's ulceration, kind of discussed in the last couple studies, lesions greater than 2 centimeters, poorly differentiated tumors, lymphovascular invasion, and then that failure to achieve eradication of dysplasia after 3 treatments. So these are patients that, if you run across these, potentially referring to a surgeon would be a good idea. So this, for the, now kind of going into the meat of types of esophagectomy, I'll kind of be brief on this, but there's 3 types. The transhiatal, which is an abdominal and cervical incision, the Ivor-Lewis, which is a chest and abdominal incision, and then the 3-field, which combines all 3 cavities, also known as the McEwen. There's different options for conduits. The gastric conduit's the most favored just because it has 1 anastomosis versus the colon interposition and the jejunal interposition, how you tend to have 3 anastomoses. And nowadays, these are being done both minimally invasive and open. There's definitely a higher push toward minimally invasive. And this was a meta-analysis of examining both. So the minimally invasive versus open esophagectomy. Minimally invasive esophagectomy had a shorter length of stay, reduced total complications, including pulmonary and cardiovascular, and lower in-hospital mortality. It did have an increased OR time, and there was no difference in the number of lymph nodes resected, GI complications, and anastomotic leak. So there are some favorable outcomes with newer techniques. Again, this was another group in Pittsburgh who looked at over 1,000 patients, and their operative mortality after minimally invasive esophagectomy, either McEwen or Ivor-Lewis, was 1.3. They had no difference in anastomotic leak or length of stay, both ICU and overall, but there was less recurrent laryngeal nerve injuries or palsy in the Ivor-Lewis group, just avoiding that cervical neck incision. So overall, the steps of what we do in Austin is a minimally invasive McEwen. So you do a thoracoscopic mobilization with a lymphadenectomy, gastric mobilization, and conduit creation. Then you make an incision in the neck and create your esophagogastric anastomosis. We treat the pylorus. Typically, we're using Botox, and then we place a jejunal feeding tube. And so this is a quick video, hopefully it goes quick, of us doing that. So we open the inferior pulmonary ligament, and then here we are taking down the esophagus vein. Admittedly, this is not my best my best video. I made it last night, so forgive me. I'll try to kind of run through it. So this is us. I'm going to go through this a little bit faster. This is us taking down that esophagus vein. Sorry, here. So there's us stapling it off. I'm trying to run through this quicker. And then we're taking the lymph node packets. We're going to try to get the paraesophageal lymph nodes. And then there's a host of other lymph node packets that you want to get kind of paratracheal and cervical. And then as we move down, this is going to be, you can see our diaphragm here at the bottom. And then at the end of completion of our dissection, we're actually just putting in a chest tube and then placing the patient prone. It's not letting me go to the next slide. There it goes. So as we place the patient prone, once we complete our thoracic mobilization, a team goes to the neck to start the cervical dissection while the other team is doing the laparoscopic mobilization. And again, I'll kind of zoom through this. I know we're getting close on time. So here we are identifying our right gastroepiploic, and we are avoiding injuring that, mobilizing the greater curve and the lesser curve. And then here we are opening up our mediastinum into our prior dissected mediastinum from our thoracic mobilization. And I'll run through that. So here is our mobilization into the mediastinum. And then here we are taking our left gastric artery. And then at the completion, we check and make sure we have enough length by taking the pylorus and making sure it reaches the hiatus. We actually transect in the neck and pull it down and remove our specimen through the abdomen. So we do a little bit of a hybrid approach because I like to do an open J tube. And then here we are externalizing our specimen and checking the perfusion prior to doing our cervical anastomosis. So I kind of want to end on just volume matters. So this was a pooled analysis of 9 relevant publications with about 28,000 patients. And it's looking at volume between high and low volume centers. So there was an increase in incidence of in-hospital and 30-day mortality that was significant between those that do a lot of these operations versus those that do not. The thresholds are listed in that table. They were not standardized of what is a low volume center and what is a high volume center. So kind of to summarize, I just, there's many reasons why anti-reflux surgery and esophagectomy are needed or are beneficial in patients with Barrett's esophagus, obviously, just to treat GERD symptoms. Another is to help with eradication, both of to maintain CRIM and to in long segment Barrett's and to maintain eradication of dysplasia. And then esophagectomy should be used in patients that have a higher risk of, if their lymph node metastasis risk is higher than the operative mortality, that's when your benefit's going to outweigh the risk of the operation. Volume matters. So I want to thank our program sponsors again, Medtronic and Castle Biosciences. And I think we're going to open up to any questions.
Yeah, so thank you, Elisa. Thank you, Vanny. As a guy, many people know this, but not everybody, that I have Barrett's esophagus myself. I've also undergone anti-reflux procedures. My last surgeon was, in fact, Dr. Ferre. My Barrett's shrunk to short segment, but I think it's important what you said, Elisa, that this is not an anti-Barrett's operation. We're still operating for quality of life. We may gain some benefit there, but I think we still need to maintain those surgical principles. I'm struck as both of y'all talked about how, whether it's looking at Barrett's progression even after surgery, and then also patients who might need multiple endoscopic therapies, that it's really the biology of the patient that's driving this. So we can't really categorize people, just yet, but we're getting there. So Vanny and Elisa, how are you using these novel technologies in your practice today? So, someone's coming in, how are you looking at the different technologies and how are you going to apply them? Because I feel like, and I'll just editorialize here, that the guidelines from the ACG on Barrett's are kind of all over the place, or they're not really all over the place, but it's, expert opinion, low level of evidence. So we're all out there struggling, how to apply new technologies here, because Barrett's is a big deal, as you mentioned, Vanny, and we've got to really make a bigger impact on these patients and the disease in general.
Yeah, so for me, for example, that patient with low-grade dysplasia, I really utilize a low threshold for endoscopic mucosal resection. So I do actually consent them every single time for that initial visit and perform EMR when I see any mucosal irregularity. And that's probably my something that I feel strongly about. In addition to that, I also utilize a variety of tools, whether it be narrowband imaging, but I also consider sending the tissue, for example, like for TissueCypher, that might be something that allows me in a confirmed low-grade patient who's on the fence to go ahead and, counsel them that they might have a higher risk of progression if they're in a high risk class, versus reassure them that if they really want to avoid therapy if possible and they're in a low risk class, then give them that reassurance. I think the individual decision making is important. I also will, utilize something like Watts 3D in a long segment of Barrett's without a presence of dysplasia. And if I see anything concerning, I might bring that patient back and then do a careful examination. And again, I'm quick to consent them for EMR. I don't think that some of these new technologies are the gateway to automatically do endoscopic resection and endoscopic ablation on everyone because of that risk of prevalent disease. And so I always feel like my first job is to make sure they don't have cancer, and then appropriately risk stratify them and make an individual decision-making path for them, wherever they're at.
Yeah, it seems like we talk about personalized medicine a lot, and we're headed in that direction. Elisa, how do you use Watts and TissueCypher and all these other adjuncts in your practice?
Yeah, so I agree with Vanny when talking about individualizing these patients. Like, everybody's risk, their baseline risk factors for esophageal cancer are different, and their biology of their Barrett's is different. So in any patient that has Barrett's esophagus, usually I won't do it on just visible lesions. I'll confirm with cold forceps and Seattle protocol before I'll use Watts on my surveillance, but I will use Watts usually during all of my Barrett's esophagus surveillance. In patients that we are doing surveillance, I will send for TissueCypher and any non-dysplastic Barrett's. I have started, and it's kind of if their insurance will cover it and if patients will are okay with the risk, and depending on, again, their risk factors, even try to get them ablation for high risk lesions that are long segment Barrett's. Although, that kind of is still the question still out there, whether or not that's kind of the right move. But if they have enough risk factors for progression to esophageal cancer with the TissueCypher and the P53 being high, I will counsel them on potentially getting ablated early.
Great. We had a question, and please put your questions in the Q&A, and there's a couple coming in, but the first question from the Q&A was, is there any advantage of TIF1 versus TIF2 in Barrett's regression? Again, and cancer prevention. So again, this is none of the anti-reflux procedures that we do. I would agree with Dr. Frey completely that these are not cancer prevention operations. We know that Barrett's comes from reflux. We can stop reflux, but I think that's when, understanding the biology, as we're going to be able to do now a little bit and certainly greater in future years. But we are not performing anti-cancer operations. We do have a good prospective randomized trial comparing TIF2 or a combination laparoscopic paraesophageal hernia repair along with TIF to Nissen. Those data are being accrued now in centers like ours. And so we'll have some information there, but Barrett's is not being studied, so we won't have that information. So I think it's really important to not, I think anti-reflux surgery has an important role, but claiming that it's a cancer prevention or Barrett's reduction operation is not the way we should go. We should be doing lifestyle and quality of life operations. Okay, there's another question here. A question for Vanny. If a patient with TissueCypher high risk, or I guess they have high risk or indeterminate risk, but biopsy only shows non-dysplastic Barrett's, when do you bring them back for repeat endoscopy?
I will talk to them. It makes a difference if it's a long segment versus a short segment. It also makes a difference whether or not I look at the initial endoscopy protocol and whether, if it was another person other than myself, did they do all the things that I expect? Report the landmarks, report the length using PROG criteria. Did they see any visible lesions, and how did they report it? The more detail that's in that report and the more, or if I've done it and I did a careful examination, I am happy to give a little bit longer interval versus if there's really nothing in there that suggests that a careful inspection for visible lesions was done. So on average, probably I offer them 6 to 12 months, depending on how careful that initial exam was. But if that initial exam was not to my reassurance, I'll say 6 months or sooner if there's any concern.
Fair enough. Sounds like you're pretty aggressive. Go ahead, Elisa.
Okay. So I actually have a question on that. So at our institution, we were trying to kind of create with all of these adjuncts different protocols for different types of patients, you know, obviously short segment, long segment, high risk on TissueCypher, not, you know, do you have a kind of like algorithm that you follow with surveillance? Like, do you ever, like, in which patients are you really going to wait the 3 to 5 years versus saying, okay, you know, you had mentioned 6 months with a high risk, even though it's still non-dysplastic without any visible lesions, or, you know, what is your surveillance interval in kind of these patients that, especially in patients when you get a TissueCypher result that says high risk?
Right. So for a TissueCypher result that's high risk, I really want to bring them back, consent them for EMR, perform EMR of any visible lesions, and then make sure there's nothing there. And then I'll lengthen out the surveillance interval. Longer segments, I will err on the side of 2 years to 3 years once there's confirmation of no cancer. And then in patients, though, that are low risk, short segment, no evidence of dysplasia, I am counseling them that they're okay to wait 5 years. And some patients are a little bit hesitant, and something like a low risk TissueCypher score allows that lengthening of interval a little bit more securely, especially if they've always been used to getting it every 3 years.
Mm-hmm. Yeah, no, I think that's great. I would love to see kind of more of that in our risk stratification of how surveillance timing. Just 3 to 5 years is such a long time, especially if you have a long lesion. And I just think that some of the guidelines or society guidelines don't really reflect yet. Hopefully in the future, we'll see more of that technology involved in surveillance timing.
Yeah, we are now looking at segment length a little bit more to be able to say for shorter segments, go the 5 years, and longer segments, bring them back in 3 years. And the British Society guidelines even suggest for long segments to go every 2 to 3 years.
Yeah, I think that this is a great opportunity for AFS to create some evidence-based algorithms utilizing the new technologies that might take a little bit of time to get into the actual guidelines, because they're guidelines for guidelines, and things can get a little tough there. Final question for you, Dr. Foray, before we wrap up. Vanny mentioned that, you know, she's got to have confidence in that index endoscopy. We see lots of endoscopy reports and things. What, in your view, if you're doing that index endoscopy, what equals a great index endoscopy? What are the components that you're looking for?
Yeah, well, I think Dr. Konda had a great slide on that. But I mean, it's the more detail about, number one, the Barrett's lesions, whether they're looking at the landmarks and actually naming them, whether they're using the proper classification terminology, tells me that they know what they're talking about in the endoscopy. And, you know, I think it's—
So you mean PROG? We've got to move. People have to describe Barrett's in the PROG classification.
Yeah, utilizing meaningful language in there that communicates what they're seeing is really important to me. And if I don't see that, kind of like Dr. Konda was mentioning, you know, I likely will repeat myself.
Great. Well, I want to say thank you to everyone joining. This has been really great and educational for me. Really appreciate everybody's time. And you'll be able to replay this webinar, and it'll be available on Endoscopy Now, especially the Endoscopy Now app, within a few days, and also on the AFS, American Foregut Society website. So thanks again. Really appreciate your time. And thank you to Dr. Conda and Dr. Perret.
Thanks, Trip.
Thank you.